Okay, continuing with chapter 30, so talking about hollow organ injuries. These often have super delayed signs and symptoms. Um, you end up spilling some sort of content into the abdomen, but it takes time for that infection to develop. It can take hours, sometimes it can take days. Um, if it's your acidic type um, stomach acid, intestinal, that tends to be a little quicker because obviously it's going to irritate the heck out of your peritoneum itself. So that's going to show up a little faster, but it also depends on the size of the injury itself. You can have both blunt and penetrating trauma. We've talked a couple of times about how hollow organs do have air in there, and so you can cause them to pop or burst because of that air. Your penetrating trauma is going to cause more of a direct injury from a laceration or a puncture. Your air getting into the peritoneal cavity can cause pain, just like that severe infection or septic shock that can occur. Just having free air in there because a hollow organ or like a loop of bowel has been perforated. Perforated means that it has opened. Just that air is going to cause problems. Just like, sometimes when you get that really sharp abdominal pain that's related to gas pains. Well, now imagine that being throughout your entire abdomen. And if you don't catch it, now all of a sudden you're eating, and those acidic juices or enzymatic juices are going to be flowing through. So you have that pain first, and then you can have the infection and the shock if you don't actually pay attention to it. For solid organ injuries, they're going to typically bleed very, very significantly. You have rapid blood loss, rapid progression into shock. You can have some that just more slowly ooze blood into the peritoneal cavity, which is going to cause increasing pain over time. And that's often why in your sample history and the OPQRST, you really want to focus on how the pain progressed. So the time portion is not like what time did this occur? It's did it start at the 7 pain or whatever they tell you? Did it start there suddenly or did it build up to that? Because that'll give you more information as to how quickly they're bleeding. The liver is the largest organ in the abdomen, and so it tends to be one of the most frequently injured. It's very vascular, often injured by a fractured rib on that right lower side. So it can cause penetrating trauma even without a break to the skin over top of. And oftentimes when you have a patient that's got an injured liver, it's going to transition or refer up into that right shoulder. Your spleen and your pancreas are also very, very vascular, and they are prone to heavy bleeding as well. The spleen is most often injured from motor vehicle collisions, especially those where the seatbelts aren't placed correctly. Those that go into the steering wheel, falls from pretty good heights. And then if you take a motor or a handlebar impact from either a bike or a motorcycle, kind of comes across that upper abdomen, that's generally going to take out your spleen. If your spleen has injury to it, that tends to refer up to that left shoulder. For your diaphragm, if that has any sort of defect in it from trauma, then you may have loops of your bowel that end up herniating up into the thoracic cavity. And you may have a patient that gets very short of breath because with those loops of bowels up in there, now all of a sudden they can't take a very deep breath. Your kidneys can also be impacted by trauma. They can have a significant amount of blood loss. Oftentimes what you're going to see with this is that you'll have blood in the urine called hematuria. You may also have blood that's visible on inspection by looking at the urinary meatus. So actually inspecting the genitalia and seeing blood at the opening of the urethra could indicate that there's some pretty significant trauma to the genitourinary system. Microscopic blood from trauma is not as concerning as if you can literally see visible blood coming from the urethra itself. So assessment. This is going to be probably the more difficult of the assessments that you're going to perform. The mechanism of injury is going to be there to tell you that, hey, yeah, there's going to be injury, but determining what is actually injured is going to be pretty rough. Your patient often is going to have some of those distracting injuries that are going to pull their attention away from abdominal injuries because those tend to progress over time. That's not going to be at the top of their list oftentimes when they have something that's very visually stimulating. So oftentimes your initial assessment and then reassessment are going to be much more important so that you can make sure that you're not missing anything. For your scene size up, this is just like everything else. Make sure that you look thoroughly at the mechanism of injury so that you have in your mind what could possibly have happened to the patient, and keep those in your mind for reassessment. Even if you don't find them up front, you may find them later as things progress. For your primary assessment, perform a rapid scan just to kind of see what's going on with the patient, check the seriousness, keeping in mind that while some abdominal injuries may be very obvious, very graphic, some may be very, very subtle, and we may get called to a patient that's experiencing abdominal pain from a trauma that occurred several hours or even days earlier, and so we might not have those MOI clues like we would have on somebody that experienced an acute trauma. Don't get distracted at first because of other more profound injuries that you can actually see. Keep in mind that just looking at the patient as a whole and getting that, yeah, this person is sick or this person's not sick, will help you know that you have to look for hidden injuries. If you look at somebody, whether they have a broken arm or not, and you just focus on that broken arm and go, yeah, they're not too bad, and you kind of forget to take that whole picture, you might miss something. You're going to assess that life-threatening hemorrhage before your airway and breathing, making sure that you are, in fact, assessing it as life-threatening. We're not going to worry about anything that's not life-threatening yet. Then we go on to the rest of the ABCs. So your airway, making sure that it's open, clear, and patent. Make sure that you do early suctioning here because oftentimes if there's abdominal trauma, your patient's going to end up vomiting because of all that compression to the stomach. A distended abdomen also may not provide for adequate ventilation because they just can't take that big, deep breath. So we want to go ahead and provide supplemental oxygen early and then assist respirations as needed. For circulation, those superficial abdominal injuries usually aren't going to produce any sort of external bleeding that's significant. Your internal bleeding is going to be what we need to worry about more so. And so treat aggressively for shock. If your patient is pale, cool, clammy, that's a massive indicator that things are not good, especially if you can't find any external bleeding that's leading to that. They're bleeding inside for sure. Your transport decision, often you need to go to the hospital quickly because there's not anything we're going to do, and your patient can bleed out if you delay any sort of medical treatment. So load and go for sure. When you're talking about the history, clarify your chief complaint and ask some more questions about the mechanism of injury. You want to identify any associated signs and symptoms, rule out any pertinent negatives, and note the position in which the patient is lying. You can get a lot of information based on if they're laying on a side with their knees curled in, trying to reduce pressure on that abdomen. If they're on one side versus the other, it may indicate which organs are going to be irritated. If they're suffering from peritonitis or they have that inflamed peritoneum, they tend to just lie very, very still with their knees drawn up, but not particularly to a side. So that can give you some information there. For your sample history, you can use your OPQRST to help get more information about the abdominal injury. Ask them about nausea, vomiting, diarrhea, because that will indicate some sort of irritation to the abdomen itself. And make sure you ask how many times and over what different time period. So have they thrown up several times in a very short amount of time? Have they had increasing frequency of diarrhea? And then ask about any bowel movements or urine output. Is there any blood in the urine? Is there any cloudiness? Is there black tarry stools? This will definitely help you rule out if there's gastrointestinal bleeding or if there's bleeding in the urinary tract, which could indicate some sort of injury there. For your secondary assessment, if your patient is critically injured, we're not going to get to this. For your physical exam, remove or loosen clothing so that you can actually take a look at the area. Try and keep your patient's modesty while you're doing this. Look for your DCAP BTLS. It's often helpful to let your patient remain in a position of comfort. You can place some padding under the knees to release some pressure on the abdomen, even in the patient that is on spinal precaution. Try not to get too aggressive with it because that can actually cause more pain. Add little by little to see where you can stop. They'll say, yeah, that feels better, and then call it a day right there. You want to make sure that you palpate the abdomen. Start with the one that's furthest away from this pain or injury. If you start there, then they're going to tense up and you're not going to get a good idea of what's going on throughout the rest of the abdomen. If you start away, they'll tend to stay a little more relaxed so you can get a better idea of the abdomen overall. Then make sure that you go head to toe as well so that you can identify any other injuries. If you find a life threat, obviously go ahead and stop and fix it. Make sure that you don't forget the back because your kidneys are more so to the back and side. You have to make sure that you look there for tenderness, for some swelling, bruising, etc., so that you don't forget about those. Oftentimes that pain is going to radiate elsewhere, but you still have to check to make sure that you don't miss something there. You want to obtain your vital signs. Many abdominal emergencies, you're going to have that tachycardia and progress to low blood pressure. Even if their blood pressure is good to start with, they could progress there very, very careful or very, very quickly. So get your baseline and reassess frequently. If your mechanism really suggests an isolated injury, you can focus your physical exam there, but make sure that you have checked for any exit wounds, additional puncture wounds, etc., to make sure that you haven't missed anything. If we do have a knife that's impaled or any other impaled objects, you want to stabilize the object with supportive bandaging. We're not pulling things out. We'll continue on in the next one.